Thank you, Dr. Bansal. I think there were some issues in the transmission of the voice. All the same, it was very informative. We'll go on to the next speaker by Dr. Sadanand Shetty. He's going to speak of the role of ionotropes in management of heart failure. Dr. Shetty?
Thank you, Dr. Mahapatra and team. The topic given to me is ionotropes, when to use in ICU, and more so in heart failure, though there will be little discussion, heart failure related hypotension, etc., which previous speakers, both Dr. Ponde and Dr. Kerkar alluded to. I will come to that. Basically, what we mean by ionotropes are a group of drugs that alter the contractility of the heart.
You're very sick.
Positive ionotrope increases the force of contraction, whereas the negative ionotropes weakens the heart. Now, the rationale for ionotropic use, ionotropes are indicated cardiogenic shock following myocardial infarction, acute decompensated heart failure, which is a topic of our interest, and low cardiac output states after the cardiac surgery or around the cardiopulmonary bypass period, etc. Reduced cardiac output leads to tissue hypoperfusion and subsequent hypoxia, and the metabolism switches from aerobic to anaerobic, and therefore the formation of lactic acid, and if left untreated, it can result to multi-organ failure and death. And it's very important to recognize these entities, arterial pressure, and maintaining the perfusion to the vital organ of the tissues. And ionotropes increase basically cardiac output, increasing both the stroke volume and the heart rate. But in the failing heart, as we know, according to Starling's law, we have a limitation. We can't go on stretching the heart by using ionotrope, because up to beyond the physiological limit, the cardiac output won't increase, and that's why the cardiac output will start dropping rather than increasing, and that is why optimizing or a combination of cardiac vasopressors or ionotropes is important in such situation. Now we must remember that though in a heart failure we have to see things like hypovolemia, which Dr. Ponde in the first case mentioned, basically it was reduced preload, reduce the effective circulatory volume to stop the diuretic, antihypertensive. We think heart failure means straight away we jump to the heart failure therapy. Is another area where you have to keep it in mind, where you got a weighted cardiac output. Today in our practice we do the procal regularly whenever there is a fever or suspicion of septic shock. And in a heart failure patient, there could be obstructive shock due to either pulmonary embolism of the cardiac tamponade, and true cardiogenic shock, what we get in like a pump failure, heart decompensated heart failure, decreased cardiac output, is one type of shock. But these could be together in a patient of the cardiac heart failure and so on. What are the established criteria? Basically, hypotension when the blood pressure is less than 90, or the mean arterial pressure 30 millimeter less than the baseline, remaining for more than 30 minutes. And if you go by cardiac index, less than 1.8 liter per minute per square meter without support, and less than 2 with support, and adequate or filling pressure is elevated, like the LVDP around 18 and the RVDP about 10 to 15. And there is a requirement of vasopressure to maintain the systolic blood pressure of more than 90. What are the types of cardiogenic shock? We know the left ventricular dysfunction. That's what we are talking in the current topic, is the LV systolic function. All the conditions like acute myocarditis, cardiomyopathy, myocardial contusion, and in the cardiac surgery, the prolonged cardiopulmonary bypass, diastolic dysfunction due to various prolonged hypovolemia or septic shock, or due to the compression external by the pericardial tamponade, tachycardiomyopathy, greatly increased afterload, as you see in malignant hypertension, arrhythmias, VT, VFib, bradycardia, and then other structural or the valvular abnormality giving rise to this type of dysfunction. Now, RV dysfunction also we have to keep it in mind in case of heart failure, and this is again greatly increased due to the RV dysfunction commonly due to greatly increased afterload. And another thing we have to keep it in mind is the pulmonary embolism, vascular disease, pulmonary fibrosis, ARDS, and of course RV infarction in an acute infarct setting. This is the two important things. Must remember the volume status. Whenever we see patient in hypotension, whether it's heart failure or otherwise, we have to see the volume status, whether patient is wet or whether his patient is dry. And also we have to see the peripheral circulation. Is it a cold or warm? The worst is the wet and the cold, as you see in classic cardiogenic shock, where the cardiac output index is reduced, increased vascular resistance, increased capillary pressure. Whereas here in dry, the cardiac output reduced, but the PCWP may not be much. Whereas if you see in the warm state, basically in vasodilatory cardiogenic shock or a mixed shock, and also the vasodilatory shock. So remember this, wet and the dry and the warm and the cold for assessing a patient of a shock. And if you remember these three things in my talk, I think I have done justice to the topic. The goal of therapy of, like a shock in heart failure or primary etiological therapy, revascularization, emergency surgery, etc., symptomatic relief with the elevation of the congestion, diuretics we may have to use, but we have to carefully assess the venous return and also the hemodynamic stabilization by the ionotropic or the vasopressor. Remember, ionotropes increase the myocardial contractility, vasopressor increase the vascular resistance. We can't use ionotropes alone. In a case of shock, we have to use also vasopressors. And what are they? We will discuss. The basic principles on ionotropic therapy, etiology, clinical condition, hemodynamic characteristics. We know that the lowest possible dose we have to use for the shortest duration. And most of the time, combination of the agents, like maybe noradrenaline and dobutamine or dopa and dopamine, etc., both combining the ionotropic and the vasopressor effect is more important. But we don't have any sort of, the strategy which ultimately sort of reduce medium or long-term morbidity or mortality in shock. And that is why whatever we are doing is buying time till we get the basic condition getting rectified. We have to remember these receptors and the location and what are the response of this stimulation. Beta 1 is in the heart, beta 2 vascular and bronchial smooth muscle cell, alpha 1 is the heart in the vascular smooth muscle alpha 2, renovascular D1 and V1 vascular smooth muscle, V2 renal collecting duct. These are the important receptor, the location and the response to stimulation we must remember, because a particular drug either will be selective beta 1 or maybe selective beta 2 alpha 1 and beta 1 alpha 1, etc. So this is important for us to remember this group of the receptors. What are the conventional ionotropes? Three major classes of conventional ionotropes which are available to us are: one is the beta adrenergic agonist like dopamine, dobutamine, epinephrine, and norepinephrine, and the phosphodiesterase 3 inhibitor, which are milrinone and embrinone. We don't use any more embrinone. And then the calcium sensitivities are called leucomindone. And these are the common phosphodiesterase inhibitor. Out of that, embrinone we don't use at all. Milrinone is one drug which has got both dual action. There is a positive ionotropy and vasodilatation, both in the systemic and the pulmonary. But therefore, it doesn't have. They are like a ionodilator. They are not ionoconstrictors. So we have to have some systemic blood pressure to use this drug, so that BP should not fall down after starting this therapy. Three predominant use: patient and a chronic beta blocker therapy. Dr. Kane is going to discuss on the beta blocker and heart failure. There's the role of this milrinone and, for example, the phosphodiesterase inhibitor may come there. Patient with severe pulmonary hypertension, pericardiopulmonary bypass. Of course, embrinone is not used because of the thrombocytopenia. Now, the calcium sensitizers are dual mechanism, leucomindone, positive ionotropic as well as a vasodilator. So they are more as a ionodilators. We have many studies, but there is no any survival benefit. Is more of a symptomatic, and the vasodilatory properties because of the opening of the ATP sensitive potassium channels, and plus they have additional lusotropic effect and indicated again chronic beta blockade and severe PAH. And normally we don't give for long period because it's got a long half-life, and normally for 24 to 48 hours. What are the choice of ionotropes we must use when the blood pressure is around 70 to 100? And if there are no symptoms and signs of shock, ideal is a dobutamine, because there's a positive ionotropic drug, basically beta 1 action. And if it is BP in the presence of signs and symptoms of shock, maybe dopamine is important, because we want the alpha action. And if you use both moderate dose or dobutamine combination is the preferred. In general, most of the time we are using this because of the alpha 1 stimulation of the dopamine. When the blood pressure less than 70, norepinephrine is the drug which we use nowadays, and norepinephrine is preferred over dobutamine, due to the increased mortality in the recent trials. So of late we are not using dopamine much, but norepinephrine. Dobutamine may be given along with the norepinephrine to improve the positive, the cardiac contractility. Types of ionotropes, vasodilator ionotropes and vasopressor ionotropes. So for short-term use, dobutamine and milrinone, they are vasodilating. They don't have vasoconstrictor. And dopamine, norepinephrine, epinephrine, vasopressin, vasopressor ionotrope. They have got a predominantly contractile. And this is what classification of vasoactive agent. Direct ionotropic effect, yes, they are ionoconstrictors. That means norepinephrine, epinephrine, and dopamine. Ionodilator, dobutamine and phosphatidylcysteine, milrinone, and vasoconstrictor, phenylephrine and vasopressin. And vasodilator, of course, they don't come in the today's like in ionotropes, but as a part of completing the topic. So ionotropes basically dobutamine, milrinone. Ionoconstrictors are norepinephrine, epinephrine, dopamine, and vasoconstrictors are predominantly vasopressin and the phenylephrine. These are various, the mechanism action given and the dose what we are using. Of course, we have got novel ionotropic agent which are in the pipeline. In that, omecamtiv mecarbil has been already is available abroad, and then there are some other drugs which are on the pipeline. Of course, this galactic heart failure study is already released, and now it is the omecamtiv mecarbil is supposed to be one of the important drug in heart failure management. Now, ESC guideline for ionotropes very clearly says for acute heart failure, 2BC as a short-term IV infusion, and the leucosamidin and PD inhibitor like the milrinone, 2BC, and of course ionotropic agent not recommended unless the patient is symptomatically hypotensive. We must remain symptomatic. Just on the level of BP you should not touch. American AHA guideline also tells us 1C until the definitive therapy, and 2AB, 2BB, 2B as a short-term therapy, long-term therapy, or a continuous ionotropic therapy. So just to summarize, the last slide is vasopressors and the ionotropic drug support can be life-saving in shock states when the cardiovascular system fails to maintain adequate organ perfusion for survival. Careful vasoactive drug selection matching the pharmacological effect to the underlying pathology may optimize the hemodynamics and reduce the adverse effects. Division of vasoactive drugs into vasodilator, ionodilator, ionoconstrictors, and vasoconstrictors facilitate understanding of their hemodynamic and adverse effects. And this is the way we must remember the vasopressor agents. Ionodilators and ionoconstrictors act as ionotropes output to enhance contractility, while vasoconstrictors and ionoconstrictors act as vasopressor to increase the mean arterial pressure, while they enhance vascular tone. And the recent clinical trials established norepinephrine as the first-line vasopressor drug for a broad range of shock states. Thank you.